Hello, my name's Robert Hercus. As the Chief Medical Officer here at the Commission, I'm pleased to welcome you to this, the third of our Better Care Everywhere series program. In the spirit of reconciliation, the Australian Commission on Safety and Quality in Healthcare acknowledges the traditional custodians of this country throughout Australia and their connections to land, sea and community. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islanders people today. Thank you for joining us for our live broadcast. Today's webinar is entitled Preventing a Problem and focuses on opioid prescribing in hospitals. Post-surgical opioids can set many patients on a journey toward opioid harm. In this webinar, we will be giving practical advice about how to change prescribing practices in your hospital and working with your primary care providers to prevent the problems associated with ongoing opioid use. The Commission has a national role to lead and coordinate improvements in safety and quality in healthcare across Australia, and we see that the improvement in opioid use is a big part of this. This webinar is live and interactive. I encourage you to post questions and use the chat function. The chat function can be found on the purple speech bubble on the top right-hand corner of your screen. Please make sure if you have questions of the speakers that you send them there in the chat function. The orange icon is for notifications or audience messages from us. The green icon allows you to refresh your screen should you experience any issues, and the red cross icon allows you to exit the webinar. We have 3 presentations today, and then all of our speakers are on standby to take your questions in our question and answer session. The first speaker is Dr. Chris Hayes, who is a specialist in pain medicine at John Hunter Hospital in Newcastle, New South Wales, and director of the Hunter Integrated Pain Service. For those of you who tuned into our previous webinar, Stopping the Habit, please note that Chris is giving the same presentation in this webinar. The next talker will be Dr. Jennifer Stevens, and she will talk about taking the wheel, how to change prescribing practices in your hospital. Dr. Stevens is an anaesthetist and pain specialist at St Vincent's Hospital here in Sydney. And then, really interestingly, I'd like to introduce you to Dr. TJ Kanhere. TJ works with Dr. Stevens as a registrar training in pain management, again at St Vincent's Hospital, but he has a past life as a GP, so his insights will be really interesting. I now would like to introduce the first speaker and the first of our 3 sessions, Dr. Chris Hayes on reconsidering opioids.
It's good to be here to talk about better care everywhere in this program series. I'm Dr. Chris Hayes, and my topic today is reconsidering opioids. A little about my background. I work at the John Hunter Hospital. I find it a privilege to be in the public system and have that less complexity that might come from patients paying for services. I work as part of Hunter Integrated Pain Service. We have quite a track record of looking at the interface between specialist practice and primary care as it relates to opioid strategy and broader approaches to pain. Our Brain Man series is one offering of interest into the space, and particularly the video Brain Man Stops His Opioids that's available on our website. In terms of professional organisations, I'm currently a board member of Pain Australia. I'm a past Dean of the Faculty of Pain Medicine and have been involved with the Pain Management Network of New South Wales Agency for Clinical Innovation over a number of years. From my early days as a pain specialist, I've always been interested in a broader and expansive approach to pain management, as is reflected in the biopsychosocial model. One does recognise, though, that there is the risk of that narrowing down to a predominantly biological focus if one pays a dominant emphasis to the first part of that, the bio. And the Faculty of Pain Medicine and other organisations have suggested the slightly long phrase socio-psycho-biomedical as a way to get away from that biological or biomedical dominance. From our team's perspective at Hunter Integrated Pain Service, we have in consumer-friendly language talked about a whole person approach as illustrated by the 5 fingers on screen there. And you can see that opioid strategy is one component part under biomedical, but there are other parts that I would argue are more evidence-based in the treatment of chronic pain and have a greater chance to bring long-term pain reduction and perhaps resolution. The clinician going broad is one thing, but there may be in some situations a reluctance on the patient's part to change behaviour. So hence this slide is part of what really motivates me in day-to-day practice. The diagram on the left is from Susan Michi, who's a behaviour change expert in the UK. The behaviour change wheel, as it's called, with the central green circle illustrating the patient's capability, opportunity and motivation. This recognises, though, that even if the patient is not motivated or has limited capability and opportunity, that there are things that can still be done, as represented by the red middle circle that talks about what the clinician can do, and the outer grey policy circle that talks about what can happen in terms of legislation, regulation and so forth. So there are multiple words there in that middle circle. From our team's perspective, what we as clinicians often end up doing is applying a mix of empathy and boundaries. If one applies tension to both poles, both ends of the rope in the tightrope analogy, one uses empathy, which draws the patient in, and therapeutic boundaries, which may alienate them. But in using those two things together, it brings tension to the rope and allows the person to progress as the tightrope walker. All relevant to the context of opioid deprescribing and what are the alternatives available. So enough about me and my areas of interest. As we go through today's talk, I'm going to run through the scientific evidence base just briefly, really just a quick glance at some key studies from 2018. Then I'm going to talk about how this translates into practice in the Australian sector, and then look at the policy and regulation space as that is implemented at the moment across Australia. And then finally, just some recommendations, whether you be in the primary care or hospital settings. So as we look at evidence, it's worthwhile asking the question of what happens if we get this right on one hand, what happens if we get it wrong on the other hand. And there are certainly examples around the world, particularly in the United States, I think, of what happens when we get this wrong and opioids are overused. We have a lesser degree of problem in Australia, but certainly we are not problem-free. I would argue that if we are not able to implement current evidence satisfactorily, this leads to an increased burden of illness for our patients. It leads to over-medicalisation and ineffective treatment. It distracts people from the treatments that really work if one focuses on opioids in the treatment of chronic non-cancer pain. 3 studies from 2018 I want to touch on. The first is the most recent systematic review and meta-analysis by Bussi et al. From 2018, as I mentioned. They looked at 42 high quality, as they classified them, randomised controlled trials, noting, however, that only 9% of those were non-industry funded. So one wonders how high quality some of these were and whether there was potential for biasing these studies in the direction of a positive response. You can see, however, the forest plot, apologies for the small figures there, but you'll be able to see from the plot that there was, when you average the results of these 42 studies, a shift to the left, meaning a representation of opioids having a positive treatment effect. However, it was only a very small treatment effect. If you average all that out, it was less than 1 point on the 0 to 10 scale. In fact, 0.69 centimetres was the amount of shift on a 10 centimetre scale. So this was statistically just significant, but we would say that that is not a clinically significant benefit in day-to-day practice. There was no difference noted in this study, interestingly, between the different categorical types of pain: nociceptive pain, neuropathic pain, or nociplastic pain. It has been argued previously that neuropathic pain is particularly resistant to treatment with opioids, but that is not something that comes up in the literature. In fact, neuropathic pain responds just as well, or depending on your perspective, just as poorly as any other types of chronic. To move to the study, it's known as the SPACE trial. This was from the United States. Again, 2018, Erin Krebs and colleagues took a pragmatic randomised controlled trial, meaning that it wasn't blinded. And in Veterans Affairs patients, they found 240 opioid-naive people who had either back pain or pain associated with osteoarthritis of the hip or the knee. And they randomised them in a non-blinded way to receive either opioid or non-opioid medications in primary care for 12 months. The mean pain intensity at the beginning of the trial was 5.4 out of 10 in both arms. What they found, interestingly, was that in the opioid group, that pain scores were consistently worse than the non-opioid group at all time points over the year. Also, they found that adverse effects were worse in the opioid group. Pain interference was no different. The study, again, 2018, McPherson and colleagues from the United States again, and Veterans Affairs patients. They took 550 people who had been on long-term opioid therapy for chronic non-cancer pain, and they discontinued them. You can see the types of pain as they classified them there, mostly musculoskeletal pain, smaller percentage of headaches and neuropathic pain. What they found with discontinuation is essentially it didn't make any significant difference to their pain. The median pain intensity before discontinuation, 4.8 out of 10, and post-continuation just marginally lower at 4.6 out of 10. The graph here subclassifies those patients into those with severe pain in the open circles, scores around 8 out of 10. Moderate pain, the triangles, scores about 6 out of 10, and mild pain in the closed circles scores about 4 out of 10. And they tracked each of those subgroups over time, and you can see essentially what they concluded, that pain either did not change or reduced slightly as people discontinued long-term opioid therapy. I think this slide very much addresses a common fear of patients when opioid deprescribing is suggested, that they might go back to previous levels of intolerable pain. This study clearly suggests otherwise. How does this translate into clinical practice in Australia? The evidence essentially says that opioids don't work for chronic non-cancer pain, and one would recognise a degree of harm as well. How are we doing in terms of translation? I would say that variability is the key problem here. The evidence that we have available is that there is a fairly large variation in clinical practice that is unrelated to the patients themselves and more related to the prescriber and their beliefs and habits of practice and prescription. The Australian Commission on Safety and Quality in Healthcare has done a substantial amount of work in this area, and their Atlas on Healthcare Variation, which has been repeated a number of times, has looked particularly at variation in opioid prescriptions dispensed per 100,000 people across different postcode areas in Australia. And this is a map from the first atlas that shows in the darker blue areas of high opioid prescription, and then in the softer colours areas of lower opioid prescription. So one can consider what leads to the areas of high prescription. Perhaps it's the low socioeconomic status of those areas. A lot of those areas are rural and remote. There may be lack of access to alternative services being a factor as well. The Commission on Safety and Quality in Healthcare, as I mentioned, have done work looking at opioid prescription over a number of years, and you can see that in the period from when they were starting to measure back in 2013-14 through to 2016-17, that there has been about a 5% increase in the number of opioid prescriptions per 100,000 people per year. Between these last two study periods, 2015 and 16 and 16-17, there seems to have been a levelling off. It will be fascinating to track that over time. Really, given the scientific evidence being as it is, we would like to see a clear downturn in opioid prescriptions, given that most of these are for chronic non-cancer pain. In addition to the dispensing increasing by that 5% over the study period here, there has also been an increase in the clinical variation between areas of high and low dispensing. So that's gone up from 4.8 to 5.1 fold over the study period. In 2016-17, the last period studied, 1.5% of our Australian population was on an opioid on any given day, and that amounted to 3.1 million people who had one or more opioid prescriptions dispensed in that year, and that was most commonly oxycodone. To take another study, because that opioid atlas has looked more at the primary care setting. This study I've chosen just because it gives us a little insight into what happens in the hospital setting, and one can argue about the respective responsibilities of primary care versus the hospital system in creating the overuse of the opioid problem that we have at the moment. This study from 2019 looked at opioid dispensing in a DVA population, opioid naive, admitted to hospital for surgery in 2014-15. There were 24,000 of those people, and it followed them for 12 months afterwards. So 15%, just over, were discharged on opioids, and then as these people were followed, of those 15%, 3,907 people, a subgroup, relatively small but substantial when you look at the size of the overall cohort, 3.9% of those discharged on opioids became long-term users, defined as those using opioids for greater than 90 days. So as I sit back and analyse this, we look at a combined contribution from the hospital setting and primary care in contributing to opioid prescription in the Australian setting, and I think there is a responsibility in both of those sectors for us to begin to do something differently. Looking at harms, this is part of how opioids translate into clinical practice. Death being the worst harm, we can see that there has been a rise in deaths over the years. As you look on this graph plotted from 2008 to 2016, these are opioid-induced deaths, and the unbroken line at the top of the graph includes all opioid-induced deaths, as opposed to the broken line, accidental, and the dotted line further down, intentional overdose deaths. If you look at the figures in the last couple of years, opioid deaths account for about 3 people per day across Australia, which is very similar to the death rate from the road traffic accident cause. Mostly looking at these opioid deaths, they are unintentional overdoses, as you can see from the graph, and middle-aged males on pharmaceutical opioids, often with other pharmaceutical substances such as benzodiazepines, are at greatest risk. So before we move on to policy, the bottom lines: opioids are not effective for chronic non-cancer pain. There is a substantial risk of harm, and there is a substantial variation in the way opioids are prescribed by different doctors across Australia. Government are concerned about this, and so hence there have been recent changes in policy across the country. From an advocacy perspective, Pain Australia are playing an important role here in taking the voice forward from consumers and clinicians to government via an evidence-based filter. So important pieces of work in 2019 were the Cost of Pain report, a piece of work done by Deloitte Access Economics, sponsored by Pain Australia, and also the National Strategic Action Plan. So the Cost of Pain report showed 3.24 million Australians in 2018 with chronic non-cancer pain, and 2/3 of that group were of working age. So there are certainly substantial economic implications of this. The annual cost was $73 billion per annum, and there was a call in that report to support general practice education, providing more resources also to general practice, and an emphasis on multidisciplinary care. The National Strategic Action Plan is a call to government to support all of those aspects. Thinking beyond advocacy into our complex policy and regulation sphere in Australia, we have a number of groups involved in this. The Medicare Benefits Schedule obviously determine item numbers and the availability of alternate treatments beyond the pharmacological. We have the Pharmaceutical Benefits Scheme looking at medication subsidy, and as GP prescribers you will be aware of the authority requirements that have changed there. The Therapeutic Goods Administration are responsible for determining drug indications, perhaps their most important role, also product information, consumer medicine information, and recommendations to pharmaceutical company sponsors. I'll talk about their change in the indications for opioid therapy in a minute. Fourthly, there's the role of the state health departments that regulate authorities for opioid prescription in cases of opioid dependency or addiction. There's a further role under the state jurisdictions to bring in real-time opioid monitoring that's available at the moment in Tasmania, Victoria and the ACT, coming though to other states shortly. The Therapeutic Goods Administration earlier in this year changed the indication for opioid therapy to say this, that opioids are no longer indicated for chronic non-cancer pain other than in exceptional circumstances. Interestingly, they haven't defined exceptional circumstances, which means that the onus is on the prescriber, if questioned, to be able to say, why is your patient representative of an exceptional case? Looking at the evidence, which leads on to what are the policy indications for opioid prescription, it's very much accepted that acute pain, cancer pain, palliative care and treatment of opioid dependency are mainstream indications for opioid prescription. Government will not question your prescribing practices in those areas. Very much different to chronic non-cancer pain. So to conclude this talk, I just wanted to focus on some recommendations for the hospital sector firstly, and then primary care. So in the hospital sector, for those of us who work there, I think this is very much about addressing patient expectations wherever we get the opportunity to, which may be in a pre-admission clinic, during the admission phase itself, and then most importantly at discharge, that we create the expectation that opioids are an evidence-based treatment for short-term pain. However, they will be weaned and ceased, and we're not initiating them with the expectation that they would be used in the long term. Another important point from the hospital system at point of discharge is that dosage should be individualised according to what the patient has used in the previous hours. I think in the hospital system we've been often very much guilty of giving patients a standard pack of 20 endone tablets, for example, when they have used no opioids at all in the last 24 hours. We need to, if we're prescribing any opioids at discharge, need to make sure that that's appropriate in the context of patients' use over the preceding hours. Third point here emphasises, I mentioned, this is short-term use and that there is a clear plan to cease, and that this plan is communicated both with the GP and the patient. Otherwise, we do set up this situation where perhaps a vulnerable patient goes to the GP and says, these opioids are very helpful, thank you, can I stay on them for a long time? We don't want to place the GP in that situation. What can we do in primary care? Firstly, do not use opioids for chronic non-cancer pain, I think, is a good rule, recognising the TGA's statement that there may be exceptional circumstances where you may choose to do this, but as we look at the scientific evidence, it is very hard to discern what that exceptional case might be. I would suggest, and this is advice very much in the National Prescribing the National Prescribing Service's recommendations, to have a conversation about opioid weaning anytime you meet someone with chronic non-cancer pain on opioids. Thirdly, it is very reasonable to have some shared decision-making with the patient and negotiation in this, but the issue is to negotiate when the reduction might start and the speed of reduction, not negotiations about whether or not to reduce. Fourthly, in terms of the practicalities, I would say that a standard reduction may be a monthly step down in dose, and you might come down each notch by about 10 to 25% of the starting dose. The fact that this is a standard plan means that you would be free to negotiate some non-standard version if you wish. Clearly, there are contexts where you may want to reduce much faster than this. Equally, there are some situations perhaps where patients are very fearful, where you might come down a little more slowly. And finally, if during the reduction it emerges that opioid dependence or substance use disorder is the dominant problem, then you can always switch to a drug and alcohol program and get the patient referred for consideration of opioid agonist therapy in that context. In that situation, there's much more of an emphasis on opioid maintenance for a time rather than the steady push towards opioid reduction that is part and parcel of pain management. So thank you for listening. I will be available in the next segment for questions and answers before we move on to the further talks in the series. Thank you for listening.
Thanks very much. So I'd like to take you through some really practical ways that you can change prescribing within your hospital and hopefully improve things for your patients around opioid prescribing. So how did I end up here? I'm not somebody who really enjoys public speaking, but I feel like I've now got a story to tell, and part of that story is how poorly I think we were performing with opioids within our service to start with, and how we've changed things around, and how now I think that we've got some data to show that we're doing better for our patients. So for me, this started with the pharmacists within my hospital. And they came to me one day and said, look, Jenny, we're going to have to hire an entire new pharmacist just to cope with all of the discharge prescribing of endone. And that shocked me enormously. So we were very lucky at St Vincent's to be one of the very first hospitals in New South Wales to get electronic medication records. And so we were able to go back and look at the data from 2005 through to 2014. And we realised that prescribing of endone tablets for discharge had gone from less than 1,000 tablets a month right up to almost 3,000 tablets a month in this period of time. And that was with no change in the amount of other prescription opioids. So nothing else was going down to compensate. So this represented just a large increase in the amount of opioid that we were sending out into our local community. And that scared me because of the data that I'd seen coming out of the States of the link between the increase in prescribing and the increases in morbidity and mortality that they were seeing. So I wanted to put this into context, and this is where the Atlas of Healthcare Variation was really crucial for me. So if this was what was happening in my little area, were we the only ones? Was there anything else going on around us? And so I looked at the data for New South Wales, and in fact, as you can see, the lightest areas represent those where there's lower rates of community opioid prescribing. The darker areas represent higher rates of community opioid prescribing. So in fact, in our little metropolitan area, we had at the lower end of the rates. And this played out throughout Australia. So you can see the really pale areas, they're remote parts of Australia where actually there's not very good access to medical services, and so there's very low rates. Little metropolitan areas where there's slightly higher rates, and then there's these regional hubs, and particularly the coastal hubs, where there's really quite high comparative rates of community opioid prescribing. So this is just one of the examples of a type of data that's available to us when we're looking at what we need to concentrate on in our local hospital. And so actually lots of other people have done the pill counting for you. They've looked at the morbidity and mortality. They've tabulated these, and it's a matter of gathering that data so that you can put what's happening in your hospital into context and work out where you need to take action. So it allows us to go from just, as I said, straight pill counting in order to progress to patient-reported outcome measures, the things that are really important to patients. So these are the sorts of data sets that are available. So the first one we're going to look at is the geographic area. So this is where the Atlas comes in. So on the left here, you've got widely available dispensing data. This is from the first Atlas of Healthcare Variation opioid section. And on the right there, you can see data provided by the Pennington Institute. So this is publicly available data. They put out a report every year. And what they look at is unintentional drug-induced deaths. Now you can see there, it's very obvious. There's this very clear association between the areas where there's high rates of dispensing and the areas where there's high death rates. And I'm not saying that one necessarily causes the other, but it means that in your same geographic area, you've got these two problems. And you can really drill down in your local area. So for example, I've just pulled out randomly for Brisbane North. So this compares a metropolitan area, whereas you can see you've had these gradual increases in drug-induced deaths over time. And then compare it to a, fairly close but regional area in the Gold Coast. And you can see that these regional hubs, particularly the coastal ones, have seen really big increases in drug-induced deaths. And compare that to a place like where I work, right in central Sydney, we're right next door to King's Cross, where there's traditionally been a lot of drug-induced deaths, and how we've seen less of an increase in these sorts of areas. So it allows you to put your hospital into a geographic context without collecting any more data yourself. Then you can access this data to work out what are the drugs that are causing mortality in your particular area, and you'd be surprised how different it is from one area to the next. And again, I've just pulled this out of the Pennington Institute report at random. So this is comparing drug-induced deaths from 2014 to 2018 with a decade previously. And let's just pick out, say, the stimulants, and you can see that Queensland has got an increasing problem with deaths from stimulants, and also a large increase in deaths from pharmaceutical opioids over that period of time. So it goes through all sorts of different drugs and allows you to sort of drill down into what are the ones that are causing harm within your community at the moment. And it can be particularly interesting if it's something like pharmaceutical opioids or heroin, which sometimes people progress onto, so that you know that you've really got to tackle things within your hospital. So once you've done the context, it's very important, if you're going to make changes and drive change within your organisation, that you can look now at your local hospital and get quite detailed data about what's happening within it. So it's going to vary from state to state, unfortunately, like everything in Australia. And in New South Wales, we're quite lucky in that all of our public hospital pharmacy data is centrally collated, and it's collated within eHealth New South Wales. They create a software program that allows us as clinicians to log in and view data from our own hospital, and quite detailed data that goes down to individual drugs, individual teams within the hospital. And once you start looking at teams, you realise that actually there's only maybe 1 or 2 junior doctors within that team who are doing all of the prescribing. So you're really getting down to quite individual data, but without their names assigned to it. So there's still some privacy. In Victoria, for example, there's no central collation, or much less central collation of this drug data. And so you'd need to approach your local pharmacy, your hospital pharmacy, and work out what software they have available for presenting this data back to you so that you can use it to drive change. So as I said, this is what I have access to in New South Wales, and it's called Pharmalytics. It's set up by eHealth New South Wales, and I just have a login so I can get this data any hospital, any computer within the hospital. And it's called Dashboard, and I'm just going to show you some features, the kind of things that you should be asking for if you're going to your pharmacy. So I can look at any drug, and I can look at what's happening with inpatient usage or just on discharge. I can look at a particular product, I can look at a particular strength, or I can then go down into a patient age group. So I can see what's happening in our geriatric population with a particular anti-inflammatory, for example, or with a particular opioid. I can then, as I said, get quite individual with who's doing the prescribing. So either by ward or by team. I can look at it in this beautiful chart, which is quite good for teaching. It's very visual. Or I can get into a table and get individual numbers, download those into a spreadsheet. So very, very useful. And I think it's important that you gather all this data together. You understand your context. You then understand what's happening within different units within your own hospital. And that means that as an individual, you can really target your intervention to where it's going to have most effect. And that allows you, as one person even, to have quite a big impact because you've really targeted it based on that data. So I love this quote. And I love this quote because for me, it's part of empowering our junior doctors, that sometimes they can be right and their senior doctors can be wrong, that they can be the people who are educating upwards. And so I often show this to them, and I think it hits home that for problems like this, where they've had a very different education to their seniors from 10, 20 years ago, that they can actually influence upwards, that they are the important people within the public hospital, that even though they're senior clinicians or registrars might be telling them to prescribe differently, that they can be the one saying, actually, I think this is the right way to do it. And we've seen that play out within our hospital. So 5 years ago, as I said, we were just very worried that we were going to see the same exponential increase in deaths associated with opioids that they'd seen in the States. And so the initial reaction really was just to put the brakes on the kind of prescribing increases that we were having. And so we did that, I think, quite successfully within our hospital by using this technique of taking the data, showing it to the junior doctors, and that changed their behaviour a lot. So it changed prescribing very quickly within the hospital. And that was really the pill counting phase. And I think now that we've put the brakes on things, that I feel like I have more control of prescribing. In fact, we're moving to measure outcomes that matter to patients much more. So from a practical point of view, now you've got your data, you know what's happening within your area and within your hospital. Where do you start? So I only want to mention 3 things. I'm going to race through the first 2 because they're very straightforward, and hopefully that's happening in your hospital already, and I'm going to concentrate on the 3rd. So the first one is about anti-inflammatories, and I think we just need to be very particular in our prescribing of anti-inflammatories. Pay a lot of attention to them, maximise their use where it's safe. And I'm particularly referring to use in the elderly. We've had long conversations with our geriatricians where we aim to look at which are the healthy elderly that are able to benefit from anti-inflammatories, because they, as we know, they're fantastic for incident type pain, for the type of pain you get after procedures. So we're really trying to maximise the safe use of anti-inflammatory in this group, often using just a single daily dose, time to when they're going to be most active. Really get your local anaesthetic techniques bedded down within your hospital. Great policies, great procedures, and just make them ubiquitous and not single shot techniques, where possible catheter techniques. So those are 2 of them. And the 3rd one that I want to spend most time on is slow release opioids for acute pain. And here I'm talking about non-cancer pain, and I'm talking about those patients who are opioid naive. So as you all probably know, the college released a statement in March 2018, and they recommended that people not use slow release opioids for acute pain in the opioid naive. And they did this on the basis that the side effects were higher if you initiated with slow release as well as immediate release. So increased risk of respiratory depression, a much higher rate of overdose, and particularly in that first couple of weeks after you initiate slow release. And also just this idea that once you start slow release, in fact, there's a more active weaning process. And sometimes that just trips into, slides into unintentional longer term use of opioids. But I think it is broader than that. I think that the use of slow release opioids for acute pain has just been an entire blind alley. And it's been a blind alley that made a lot of people a lot of money, but it's been of no benefit to our patients and it has caused untold harm. So this is a busy slide. I'm just going to take you through it slowly. So just as a background, we just released this paper, it just got published, and it's about what happened to prescribing of slow release opioids around the time of the statement release. So before and after the release of the statement, you'll see in the left-hand box, there was actually a large reduction in the prescription post-operatively and a large reduction in the prescription at discharge. All right, so it was a successful release of the statement and made a difference to practice. And this just resulted in a decrease in the amount of opioids that people were taking in that first few days. And it also made a difference at discharge as well. So again, that's just pill counting though. That doesn't matter to patients. how many tablets they take. But what we found, and what was quite surprising, and what really does make a difference to patients, is that in fact, if they didn't have slow release, if they had a lower dose of opioid, in fact, their pain relief was better. We're not depriving them. We're improving their treatment by doing this. And also that there were fewer side effects when they didn't get the slow release. So what we've done is gone from actually this causes problems for patients in terms of side effects, the reason for the statement release, to now saying actually, and it also doesn't make their pain relief any worse. In fact, it may make it better. So how does this trickle through into the private hospital? So this is old data from our private hospital. It's about 5 years old now. And what we found was out of 1,000 patients who present to our local private hospital for surgery, they're opioid naive when they come in. Out of this 1,000 patients, fully 10% of them were still taking opioids at 3 months. And it was specifically patients having spinal surgery. So these are people with terrible back pain but hadn't been on opioids. And 3 months later, almost a third of them are. Joint replacement, it was about 15%. So we've re-audited now, we're in the process of it. So this is incomplete data that's coming up, but it shows that we've made a big difference in patients' lives at 3 months post-operatively. We've no longer got a group who are large, who are taking opioids in the longer term with the trigger of surgery. And I think this speaks to one of my last points, and that's about people often say, what's happening once these patients get out? Aren't we just transferring this problem? We're sending patients out who are in more pain to GPs so that GPs have to write more prescriptions. And in fact, that's not what happens. And I think this audit speaks to that, because it says that if we don't start them on slow release within the hospital, if we're not prescribing such unnecessarily large amounts, the patients find it easier to come off. Their pain's no worse, but it's just much easier for our general practitioners to deal with once these patients get out into the community. And one of the consistent findings is that there is a much closer relationship between supply and consumption than there is between pain and consumption. And all we've been doing is oversupply, leading to overconsumption. So I think this helps, particularly with the slow release opioids, avoiding GPs being given the responsibility of weaning the slow release opioids that we've started in hospital. So I think if anything, it should make it easier for our GPs. So where have we ended up? Well, I think that we've ended up more responsive to individual patients. I think instead of reflex prescribing, we now think about the individual and what we're prescribing for them. I think hopefully we've made it easier for our GPs. We've certainly made it much easier for us on the acute pain round. Patients who don't come in to their surgery on slow release opioids are so much easier to treat in hospital and have a much better experience. Their satisfaction is much higher. And I think what we're trying to do is work with our local GPs and not create a community of people who are already on these drugs when they come into hospital and so have a much harder time. Thank you. I'd like to introduce Dr. TJ Kanhere. So I've been very fortunate to have TJ as my pain fellow at St Vincent's Hospital for this last year. And TJ is a vocationally registered general practitioner. And I just wanted to pass over to him so that he could talk you through his convoluted journey to starting pain training.
Yes. So thank you, Jenny.
The quick version would be good, TJ.
Absolutely. Yes, thank you for having me here. So I actually finished my general practice training in 2016. In 2017, started looking around for what I wanted to focus in general practice, worked a bit in occupational medicine, bariatric medicine, and then came full circle got very curious about pain. And I realized that, like, in all of the patient dealings that I had for patients with pain, in particular chronic pain, I didn't feel like I had a very good understanding of what the patient was presenting with and how I could help them out with. So learning more about that sponsored learning a bit more about the new changes in the way we approach pain and pain medicine. That really kicked off this whole journey for myself.
Yeah, it's interesting that you say that, because I came at pain as well from not from a I want to do pain medicine, but from a feeling of inadequacy, just feeling as though as an anaesthetist I really didn't understand enough, I didn't know how to treat it properly. And I think that pain medicine really was almost at the point of the barber surgeons probably about 20 years ago, in that there was a lot less evidence, and some of what constituted pain medicine was not the right thing to do, but we just didn't have the evidence for what was the right thing to do. And it's progressed so quickly, and the evidence is emerging, and so now there is a little bit of an evidence base around what to do. So it's a very exciting field to be part of. It's not what you'd call a mature specialty at all, and it's great to be part of an immature specialty, an emerging specialty, you'll call it. So what I'd like to get from you, TJ, in essence, is what you've learned being both in the community and in the hospital, what the differences are, and what we can do to make it easier for GPs.
Absolutely. So I think the biggest difference is that hospital admission is typically an event-based admission. So someone comes in with a issue, that issue gets addressed, they might have some more issues along the way, but the end of the hospital journey, usually for most people, is that they get discharged home. So I think hospitals have a very clear goal, which is let's get the patient home. And there's lots of reasons for it: better for the patient, better for the community, reduce risk of iatrogenesis, all the other things there. But I think that drives a lot of hospital-based decision-making. And then there's this thought process that let's get the person home, because after that, they'll be living happily ever after. Someone else can sort out the other medical issues, and that's that. I think the difference in general practice is where that's someone else, and that people come and often following a hospital admission, they have a very well-written discharge summary that has 17 points to address in terms of how to help look after the patient, and then we're stuck with 8 minutes to do what we can in that time period to do what's right for the patient in front of us. The other thing that's different in general practice is that longitudinal-based relationship where we see patients for weeks, months, years, and the relationship that develops from there, which occasionally does happen in hospital, especially with patients that come in numerous times due to various conditions, but it's much more of a driving force, I think, in general practice compared to hospital-based medicine. And I think the thing that can be done to help out is better communication from both parties. So general practitioners calling in when a patient's admitted about various issues and getting a bit of it can be an opportunity to get an update about what's happening with the patient, but also on the flip side, when a patient's being discharged, about what needs to be done, needs to be more effectively communicated to, but not just the general practitioner, but also the patient in question as well.
I find the differences there, that sort of very longitudinal relationship versus our truncated relationship often, to have some good things on both sides. One of the things that I think as a hospital doctor I can do sometimes is to be a little bit of a circuit breaker. So somebody comes in for a sentinel event, whether that be a medical emergency or an operation, and they meet somebody new. And it can be an opportunity to give a slightly different slant on education, to talk to them differently, present a range of options. Sometimes we have, well, I think on the whole, we have more time within the hospital environment. And so I see that as being complementary to what's happening in the community. Sometimes we can just be that circuit breaker that changes things quite rapidly, whereas I think probably that's more difficult within the community. Do you think that's fair?
I think so. I mean, I think sometimes the hard part is when a patient has an expectation that, having gone to an appointment many times and had the same outcome for it, especially if you're not someone new to them, so that whole dreaded scenario of colleague retiring and then the patient coming to see you on large doses of opioids, there's often a bit of a resistance and pushback saying, well, why are you being difficult, versus my previous doctor was fine and they would give me the script and there was no problem. And I think that's a bit harder to manage in a general practice setting compared to when someone comes into hospital and has someone completely brand new de novo from a different experience coming in and talking. So, yes.
So let's get to the nitty-gritty,
Sure.
TJ. I'd just like to ask you about a few little clinical scenarios.
Oh, God.
And whether how you cope with those now is different to before you came into the hospital system and trained with us.
Yeah.
So, for example, you've got a patient who has osteoarthritis of the lumbar spine.
Yep.
And has been on OxyContin 40 milligrams BD plus some breakthrough endone.
Yep.
And their usual GP is retired and that patient ends up with you.
Mm-hmm.
Now, I know I've only given you a drug history and nothing else, but do you think how you would treat that patient now compared to a year and a half ago has changed? And if so, in what way?
I think so. I mean, I think a year and a half ago, my heart would sink when a patient like this came through. I mean, because I would feel like unequipped to be able to handle the needs of this patient, and I wouldn't be sure if I could really help them out. What I would do a year and a half ago would be probably to continue the script after checking to see there was no patterns of misuse behavior or anything else, a phone call to the prescription shopping hotline, etc. And then probably with a referral to the pain clinic and a silent prayer that they would see the pain clinic sooner rather than later to help me out. I think now what I would do, I mean, all those things are still reasonable, silent prayer notwithstanding, but I would probably also get a bit more of a sense of the patient that's in front of me and also the medication they're on. For this one, I'll focus on opioids and medication mainly, but of course, a really good framework is the psychosocial biomodel or the biopsychosocial model for making sure you see the person as a whole in terms of the issues they may have, both from a biomedical, psychological, and social perspective, because all these things interplay. With this patient, they've been on OxyContin 40 milligrams BD plus some opioid endone breakthrough. Let's keep it simple and say 20 milligrams in the course of a day. So that's a total of 100 milligrams of oxycodone or, oxycodone SR per day. One really useful tool for risk stratification is to convert any opioid a patient is on into what's an oral morphine equivalent. So there's plenty of tools available to do that. The Faculty of Pain Medicine has an app, which is great. So you just plug in the numbers, the dose of opioids, and it'll tell you the numbers that they're on. But oxycodone is a 1.5 times, equivalence rate. So for that patient that's on 100 milligrams total of oxycodone or oxycodone SR, that works out to be 150 milligrams of oral morphine equivalents. There's lots of different risk stratifications for morphine equivalent dosages, but as a general rule of thumb, there's two ones that are used a fair bit. More than 100 milligrams is definitely red zone, no question about it. But I would say over 60 milligrams oral morphine equivalent is actually a more reasonable red zone marker, especially if the patient has other comorbidities like such as age or other conditions or anything else.
It's really the tipping point, isn't it, where you start going from minor increases in side effects to quite rapid increases in side effects over about 50 to 60 milligrams.
100%. And also the other thing is it's often with the patients, they've been on this medication for a long time, but as they age and have more medical issues as well, of course, then the chances of those side effects are much more pronounced as well, which is often a bit of pushback from patients when we have this conversation. It's like, I've been on these drugs for 20 years and I have problems, so, why are you? But I mean, it's a really important thing to look at in terms of risk stratification.
It's almost like they're aging into side effects.
Yes, sir. Yeah,
and that's one of the ways I sort of explain it to them was,
yeah.
At 60, you might not have had side effects from these, but actually your dose needs to reduce as you get older, so you're aging into these problems.
Yeah, and absolutely right. And even if they're not aging into it, they might have had side effects they're unaware of. So things like, for men, reduction in testosterone, for example, or effects on mood, effects on cognition, effects on memory, all of those sorts of things can be side effects of opioids. And patients may be unaware that they've been having side effects. They might just think that their mood's bad for other reasons, whereas it's from the opioids might be contributing to it. Once I had a sense of the opioid dose that they're on, I think for any patient pretty much above 60 milligrams, I think it's quite reasonable to refer into a pain clinic and get advice and a multidisciplinary team action. I would also look for the 5 A's of opioid analgesia. So this is available through the ACI website if anyone's interested. But basically it boils down to activity. So what sort of what the patient is doing right now on a day-to-day basis, how far they can walk, how far they can sit, stand, all those sorts of things, and whether they need help with activities of daily living like cooking, dressing, etc. The next one is analgesia, which we'll talk about in a sec, and go into a bit more detail what that represents. Third is looking for adverse effects, so side effects from medication. The fourth one is aberrant behaviors. So this is things like losing scripts, coming back early for refills, doctor shopping, all those sorts of potential red flags that might point to something beyond using opioids for chronic pain that might be a suggestion of opioid use disorder. And the fifth one is affect, so checking their mood and seeing that how that is and how that interplays with everything else. With the analgesic effect, often patients will say things like, if I don't take my X drug, I can't get out of bed. And that doesn't necessarily mean that that's having an analgesic effect. They might be using it for other purposes, or they might even not recognize that it's actually the time after they wake up that's the beneficial thing rather than the medication they may be taking. And a really good way to tease that out is to talk to them about the drug in question, ask them what they think it's doing, how long, when they take the medication, what is their pain like before taking the medication, what's their pain like after, how long the effect lasts for, because I can give you really good clues in terms of the effect the opioid is having, if any, and also provide options for treatment in terms of if the opioid's only lasting for 2 hours, for example, then, is there something else that we might be able to fiddle with or change the timings or whatever the case may be?
I think one of the adverse effect issues that we've gone through quite a few times, TJ, is to find something that matters to that particular patient. So for young men, for example, I will do a testosterone level and show them that it's reduced. And for most young men, that will be quite a bit of salient moment. The implications of this. Yes. For somebody who's had depression, to say to them that it might make their depression treatment resistant or worse, and we know how terrible a problem that is, and they don't want to go there again. So that can be very important to explain to them. Somebody's had fusions and they're worried that their bones are like butter and they might fall apart, to talk about the association with osteoporosis. So just teasing out what it is that's going to matter most to those patients, and I think that's quite a good way to frame the discussion about adverse effects.
Absolutely, and it's much like with smoking, where it's often talking about smoking cessation. It's very easy to talk about abstract things, but if you really hone it into the here and now things that are affecting the patient, so someone with significant financial stress, looking at the cost of smoking, in much the same way with opioids, tailoring the discussion to the person in front of you, the problems that they're having, and showing them links in the opioids that they're taking, some of the effects that they're having, and saying that these two things may be related, can be a really, really powerful driver for change. And I find that in my experience, I've been very pleasantly surprised at just how much people are happy and willing and eager to change. Often people feel trapped in the opioids that they're in because they're still in chronic pain. They think this is the only thing that helps. They've gone to their doctors in the past and all that's happened is the doses have gone up, and everyone's stuck in a situation they're pretty unhappy about. And offering a patient a way out can be a really powerful thing in terms of reducing opioids and discussing what effect that'll have on their pain levels, etc.
I think one of the problems that we hear about quite frequently and is very legitimate is issues with general practitioners who have a patient in front of them. They know that the waiting list for their local chronic pain clinic is months. And I remember you talking about learning what you might do in a circumstance like that. Would you like to elaborate?
Absolutely. So the one thing I did wish I knew earlier was that help is often just a phone call away. Getting in touch with the local tertiary hospital and asking to speak to the pain registrar or pain fellow there is a really useful way to get a little bit of phone advice. Sometimes we're a bit limited in terms of specific nitty-gritty advice we can provide over the phone. What we can also do is facilitate this patient being seen much quicker in our pain clinic. With pain clinics, the nature of the job often, at least in the clinics that I've worked with, there's often cancellations and other things that happen. And so even if a pain clinic's fully booked out, it means we can usually see someone that's more of a priority much quicker, but we have to be aware of them in order to do so. And so calling us and letting us know about the patient, the situation that's going on, is a really helpful way to get a little bit of phone advice and in terms of where to go beyond further as well. So that's something that I wish I'd known before.
All right, so one of the other common issues is if you've got a patient who's on opioids already, and they have a flare of their pain. I think that's a really common problem that happens in the community. Is there anything new that you've learned about what to do in that circumstance?
Absolutely. So actually, funny you should ask this, Jenny, but when I was leaving my general practice to go into the hospital system, I was asking my colleagues what they would like to see in the correspondence from pain teams. And the most common feedback was what to do when the patient's pain has flared and how do you handle that. And somewhat ironically, I haven't put that in my letter, so I better start, but thanks for reminding me. Anyway, but I think the key thing about it is when a patient comes to you and they have a flare-up of pain, the things that run through my head now are, first of all, has something changed in their biopsychosocial framework? So it can be, of course, is there a biomedical change to whatever condition they have? And of course, we're speaking in generalities here, but quite often there's concomitant psychosocial stresses that are also there. And that's helpful because the psychosocial stresses that are there offer an independent pathway of treatment that don't require any medications or require a different type of medication, perhaps, to the opioids and other substances. So what I would do is, the other thing I would do is sometimes when a patient comes in and they have a flare-up of pain, their distress is being communicated to you. And it's very easy to get caught up in that distress as well. But sometimes it's helpful just to take a step back and kind of get a sense of what exactly is happening to the person in front of us and what's treating it. And often you'll find that if someone comes in with a flare-up of back pain, for example, a question like saying, okay, I get where you're coming from, we're going to definitely help you out with that, but can I just ask, is there anything else stressing you out right now? Something a bit more of a overarching question can sometimes be a really helpful bridge to talk about some of the other things. Some patients won't like that, and then a small education piece about how pain, emotion, and stress can feed off each other and are linked can be really helpful to establish why you're asking those questions. And that can be a good sort of segue again to talk about this a bit more. In terms of nitty-gritty medications, that kind of thing, it depends on what the patient's on right now, but sometimes when a patient has a pain flare up, drilling down into what exactly is flared up over what kind of duration can really provide good insights in terms of how you can help them in the here and now. And often it doesn't mean increasing opioids or other medications. It might mean something like rotating, which we can talk about if we have time, or it might mean something like changing the times of medications, or it might mean instead of having it twice daily, the same amount of drug but 3 times a day, or whatever the case may be. And getting a bit of a sense of how the pain's going can be helpful with that. Yeah.
I think timing is crucial. And in my earlier presentation, I talked a lot about slow release opioids. And I think one of the advantages of focusing on immediate release opioids is that it's much easier to change the timing of those drugs to respond to incidents than it is for slow release, which just burn on in the background, probably not doing much. So that brings me to almost a personal question, TJ. And it's been quite a focus for me in the last maybe year and a half, 2 years particularly, to just change our hospital into a non-slow release opioid using hospital. And I exclude cancer pain here. What's it like working in a place where we don't use really any slow release opioids for acute pain? Do you think the patients are worse off? And I fully give you carte blanche to say that you think it's worse.
I actually think the patients are better off. And I'm not just saying that because you're sitting next to me and they got my immediate. But yes, but it's because I think there's a couple of things. First of all, like one thing I didn't touch on before, or I did very briefly, is it's often worth asking patients what they think opioids are doing for them, and it's truly remarkable the answers you get. Sometimes people think they're actually treating the pain in the sense of how antibiotics treat infection and all those sorts of thought processes. And so, but with long-acting opioids, I feel like there's a bit more of a sense that this is a chronic, persistent, pervasive condition that transcends the actual medication dose or anything else in and of itself that isn't there with the short-acting opioids. And of course, there's the negative health outcomes. But I actually think that I have not once in the last year wished that I could have prescribed someone a long-acting opioid in any sort of setting, really. Yeah.
It's been interesting how different our pain rounds are now that we're not having patients coming in from the community so much who are already on them. My job is a lot easier.
Absolutely.
The rounds are shorter.
I
Don't tell
imagine.
that to the administration. They might give us other things to do.
Exactly.
But
Yes.
it really makes a big difference.
Yeah.
And yeah.
And I think the flip side to that, though, sometimes patients do come in and they have been on large doses of Targin or Oxycontin or whatever else. And then what do you do in that setting when they've been on those slow, long-acting opioids for a long period of time? What do you do for the person when they're sitting in front of you? And I think these sorts of patients are absolutely fantastic to send through to pain clinics. And I think this is very much what we're here for and what we would love to help you out with. And in the meantime, if you're not sure, because sometimes, as we alluded to before, the wait can be quite long to see a pain clinic and have a multidisciplinary approach. It can be really helpful just to, and I'm fully cognizant that I'm giving myself more work doing this, but just getting on the phone and talking to us can be a really good first step in terms of providing a bit of targeted advice in the short term and then linking them in with the pain clinic in the long term. Yeah.
I think one of the things that I try to teach throughout the hospital is to recognise distress and to just be kind to patients who are on long-term opioids, whether it be for opioid agonist therapy, for drug use or for pain. There's some really beautiful literature showing that medical students feel more and more comfortable as they go through medical school with almost every single condition except chronic pain. And I think that one of the reasons for that is because there's been this large group of patients who come in on opioids, and it makes it's a harder problem to deal with. You're dealing with the patient and their pain, plus you're dealing with the opioids almost as a separate issue. And to try and teach them that kindness, that trying to rip people off their opioids rapidly is not the answer, that kindness is the top thing. Recognising distress is right up there. And then you deal with the drugs, but you have to, as you said, TJ, I think, establish that rapport with the patient and help them to understand that you're there for them. And I think we've been very bad in hospitals on the whole, I would say, at doing that in the past. But we're really trying to make quite a big effort that's the message that we convey to our patients first before we start talking about what they're doing wrong or with their drugs.
Yeah, 100%. And also, I would just add on one small point to that kindness. It's often the situation that a lot of patients find themselves in isn't really anyone's fault as such. I mean, the prescribing paradigm from 20 years ago is very different to the prescribing paradigm of today. And the doctors that prescribed the patients these opioids thought they were doing the right thing for the patient. So I think acknowledging that is really important, because otherwise it can end up becoming a bit of a blame game. Like, Dr. Smith did this to me, and all of those sorts of things. So being kind to the patient, but also recognizing that this is a situation they're in that is a bit outside of their control almost, and is a really good way to kind of create that discussion and talk about where to go from there in terms of reducing opioids in the future.
Well, one of the things I can say over the last year, TJ, that I've noticed about you is the way that you talk to patients is quite different. And
Really?
it's fantastic. It's really good. You can see them immediately going, this guy understands what I'm going through. And I think that was happening less at the beginning of your training year and is happening more now. And once you get that, this person understands what I'm going through, then you can proceed. And that's changed a lot,
Thank
me
you.
watching you.
Very kind of you to say.
So we might leave it there. Thanks for joining us.
Thanks, Chris, Jenny and TJ. That was a fantastic two presentations and discussion about opioid use. And I'm sure I personally have learned quite a lot from that. A reminder to everyone in the audience that we're about to have a live question session. At the top of your screen, there's a purple speech button, which allows you to submit questions for Chris, Jenny and TJ to answer. So please use that function if you can. So it's now my great pleasure to re-welcome Dr. Chris Hayes, Dr. Jennifer Stevens and Dr. TJ Kanhere to talk about your questions. And the first question we've got is aimed at you, Jenny and TJ. Towards the end of the presentation, you talked about patients having a pain flare. And you said that often you don't need to increase the opioid medication, but you might rotate the medicines instead. Could you expand on that for us? What did this mean?
Yep, sure. So what I meant by that was by opioid rotation means to take the existing opioid that a patient is on and to replace it with another opioid. And the way in which we usually do that is to convert the overall total dose per 24 hours into oral morphine equivalents. And the FPM app is quite a good resource for doing that in a quick and ready manner, and then using that as a guide for what opioid dose to prescribe to a patient. Usually one thing that we commonly do is switch to something like a buprenorphine patch, and we usually reduce the amount of oral morphine equivalents by about 25%. Would you do anything differently, Jenny? Or?
I think sometimes it's quite useful if the patient has a flare, so they're actually saying that their pain has increased, is when you rotate, you normally decrease it, as you say, TJ, by about 25-30%. If you keep the equivalents similar, actually what you can do there is give them a boost in efficacy if they're having a flare. So I find that quite a useful conversation to have with patients, to say, we'll switch you across, keep it exactly the same, but that should give you the boost that you need to get you through this flare.
My comments, thinking about where I'm mainly working in a chronic pain clinic, interacting with GPs and their prescribing, is that I used to find myself recommending opioid rotation quite a lot a number of years ago, and on reflection now I recommend it very rarely, simply because the main message now with respect to primary care management of opioids in chronic non-cancer pain is go down. So usually I would say just go down on what the patient is on. If you change the opioid, that brings a whole another equation in, and the uncertainty associated with that can often be counterproductive. And if you do get a benefit from the opioid rotation, it perhaps lulls that patient into a false sense of the promise of opioids, where it's just short-term gain that wouldn't be sustained over the long haul anyway.
Okay, thank you very much. There's quite a lot of questions here about how we manage our surgical colleagues. One of the questions is around the surgical team that insists on discharging patients on both slow release and immediate release opioids without giving the patient or the GP a deprescription information or any idea of how long you would expect the patient to need that opioid analgesia. How do you handle that when the pain service hasn't been involved, Chris?
I think it's a tricky one. Jenny works more practically in that acute pain zone than I, so let me make a few brief comments and hand to Jenny. I think, as someone alluded to in the questions, there's often a gap whereby the acute pain service bail out a few days or a week perhaps ahead of hospital discharge. So that's the window of opportunity for surgical teams to perhaps indulge in some unusual prescribing practices. So I think one can educate, one can contact the GP to rescue any damage that's been done over that window period. Jenny, over to you. You're practically engaged. I'm speaking theoretically.
I think practically engaged is a really good way to put it, Chris, because that's what I do with my surgical colleagues. I have a great deal of respect for the people I work with, and I spend quite a bit of time talking to them. I'm lucky enough to work as an anaesthetist still, So I spend quite a bit of time in the theatres, and that can be a really good opportunity just to capture them when they cannot run away. So I'll talk to them quite a lot then. The other thing I do, as I mentioned, is to start with their juniors on the team, because the senior doctors actually do realise that they're not necessarily up to date in everything that's not their primary specialty. So I found that they're quite good at sort of soaking up the vibe from the junior doctors. It's quite surprising.
And if I can add one more thing, one thing that I found Jenny did that was quite effective at helping to curtail that gap effect that we mentioned was having direct input into the discharge summaries and putting in an acute pain management plan in the summary itself. And I think that's quite helpful for junior medical officers to see what the plan would be going forward. And I think there's a reluctance to modify that too much, given that it's been written by a staff specialist directly into the summary. So that's quite an effective tool.
And after having said that, you know, how much respect I have and that I practically engage, I also, to a degree, actually name and shame.
Yep.
So one of the things that I've found incredibly effective is I'll go into the Pharmalytics program that I demonstrated in the video, and I'll capture one team's results that I know I've had really good results with, and I will go to another team that I think is not doing prescribing the way that I would like them to, or within the guidelines, and I show them that they are now the outlier. So I really show them this is what everybody else is in the hospital is doing. You are no longer in lockstep with the rest of the hospital, and I find that changes behaviour more rapidly than anything else that I can do.
Okay, thank you.
And I think
Another question.
probably the behaviour effect. Sorry.
There's another question here about practicalities of surgical teams. So with the length of stay of surgical patients diminishing by the month, how do you deal with opioid prescription for a patient who's had surgery, say yesterday, had a regional block, and is going to be discharged today? How do you judge how much analgesia you should discharge them on when they've had the regional block operating for until an hour or two ago?
That removes two of the most important ways of stating how much you need to provide for discharge. Because not only can you not look at what's happened in the last 24 hours, but the other thing is you can't ask the patient how much they think they'll need, because they have no idea what the pain is until the block wears off. So I think it does make it very difficult. One of the things that I would recommend is to get some of your CPD points. If you do a particular regular list, get some of your CPD points by ringing the patients that you're doing 1 or 2 weeks later and asking them, what was your pain score, how much did you use? And then you can use that in the future to inform your discharge prescribing. So I think that's fantastic to get great CPD points for it in the most difficult category. So that's what I would recommend.
If I can comment from the chronic pain perspective, patients discharged from the hospital setting, a tactic we would often use similarly to what Jenny's talking about is for one of our nursing staff to ring the patient in the week or so after discharge. That seems a very useful liaison step. So often we would get the nurse to ring the patient and myself or one of my medical colleagues to ring the GP.
Okay, thank you. There's a couple of practical questions now about pain management and developing a pain service within a hospital. So the first one is, our hospital doesn't have a pain service. How would you suggest we go about starting one? What are the steps?
Do you want to lead off, Jenny, from the acute perspective? It's a big question.
I do. And I work at a place where there's a co-located public and private hospital, and we have a well-developed acute pain service in the public, and I would say close to a non-existent service in the private. And so if I look at what I'm trying to do to set up a better service in the private, I'm actually starting with nursing staff. I think nursing staff provide consistency. You've often got somebody there who is there 5 days a week, They're good with consistency, with setting up policies and protocols. Nurses feel like they can contact them. So I think it's really important that you get whatever organisation is to actually fund a part-time nursing position. And then on top of that, I think you need to support that with the medical staff. But I think that's where you need to start.
And I would add to that, it may be valuable to speak to some existing pain services nearby in the same state, perhaps as you are. You can get some good mentoring and support, I think, whether it's an acute or chronic pain service, depending on what you're trying to set up. Depending on your state, there may be some overarching organisations, for example, in New South Wales, the Agency for Clinical Innovation, who have been working on developing a state-wide pain plan. So just looking around for resources beyond the hospital setting, as well as, I think, looking for levers within the hospital itself. You know, Jenny's talked about, doesn't necessarily have to be name and shame, but maybe are there some outcomes that you might audit within your hospital that point to a clinical need?
Okay, thank you. Another process
question about... Sorry, sorry about that, Robert. Just one of the ways to fund it is to get your surgical colleagues, especially in the private hospital. So I found I had little clout about getting an appointment for a nurse. And so now I'm pressuring my neurosurgical and orthopaedic colleagues to pressure management to pay for that. So you make it a surgical need, not just an anaesthetic need. Sorry, Robert.
Thank you. Another question about how you set up a pain service. And I know, TJ, in a past life you were a general practitioner, so maybe you can comment on this. Have the pain services moved with the times and started to use telehealth services to support patients remotely, and possibly more importantly, are the pain services supporting general practices and allied health practices using telehealth remotely?
So I've been lucky enough to work in a practice that has a very heavy telehealth focus. New South Wales Health, due to the nature of last year with the pandemic, has shifted as well into a much more telehealth friendly space. We often do, before we were also servicing a region in far south New South Wales, which required telehealth access in order to see us. So most pain medicine is lucky in terms of specialties in that we're able to do a lot of what we do via telehealth with effective outcomes, I believe. And Chris, I'd love to hear your input on that as well. But I think we have shifted with transition into telehealth quite well. Where possible, we always try and include the GP in the decision-making and the conversation afterwards. Sometimes in telehealth, often that means that the doctor walks in at the end of the consult for a few minutes, and that can be quite a valuable way of making sure everyone's on the same page, or whether it's calling them afterwards if it's set up in a time where the general practitioner is not there.
I would add that in a modern era, it is interesting to me that the good old-fashioned telephone still has a large place. Many of our patients are very comfortable with the non-visually linked telephone. However, we are also doing quite a bit of telehealth, including running some groups via telehealth, which has been an interesting experience. So yeah, I would support TJ. Pain services are moving with the times.
Excellent.
And
now, there's a question here about consumers. So far the conversations really have been about processes and protocols that have been set up by clinicians, doctors, nurses and allied health people. But what about bringing consumers into this conversation, especially when they have a flare of their pain? How do you deal with that?
My starting thought, thinking about setting up pain services, is that consumers can be very powerful lobbyists, perhaps, when hospital administrations and politicians aren't listening strongly to doctors who they perceive as having a vested interest. They may well listen more to consumers. That's just taking one tack on this question. Jenny and TJ, over to you.
Yep, so I think engaging consumers is critical, and it's often part of the way I like to do that is to get a bit of feedback afterwards when I've spoken to a patient, especially if I've seen them at the 3-month mark, the 6-month mark, and especially if the outcomes aren't quite as positive as we would like. And often the feedback that we get can be quite surprising. In this year last year was a bit of an exception because of the telehealth focus, but sometimes some of our consumers struggle a bit with some of the technical things required in order to access and use telehealth for things. And as Chris pointed out, transitioning to phones can be really effective in that setting to help out. In terms of flare, Jenny, I can answer it if I'm happy.
Yes, go on.
Right. So in terms of the flare, I think it's often worthwhile talking to the consumer and getting a sense of what their objective or what they're hoping to have with the pain. And often the first answer is, of course, I want the pain to be gone or reduced. But then going a bit deeper in and sort of drilling down can be really helpful to get them engaged in the process and to help manage the pain flare symptoms.
Another angle on this looks at the consumer role in helping us to co-develop website resources, other educational materials and so forth. I think that is an incredibly valuable role for the consumers.
Okay, thank you. There's a question here about regulation. Chris, in your talk, you spoke about the TGA changing the regulation to try and dissuade people from prescribing opioids for chronic non-cancer pain, except in exceptional circumstances. Can you tell us what you think an exceptional circumstance is?
That is a good question. Thanks, Robert. In practice, I think very little from our team's perspective, we would say. Although if you do look at the evidence-based indications for opioid prescribing, those being acute pain, cancer pain, palliative care, and opioid dependence, there may be some grey zone prescribing issues that abut against each of those. For example, the elderly patient who's not quite yet actively palliative, that might be seen as a grey zone, or perhaps an exceptional circumstance. You may prescribe opioids before they strictly meet the actively dying phase. Perhaps one could say the same with a complex acute pain patient, multi-trauma fractured pelvis, where opioid prescription might go on for longer than the 3-month mark that defines chronic pain. So I think if there are to be any exceptional circumstances, it's in the grey zones against acute pain, cancer pain, and palliative care and opioid dependency as well.
And one of the other grey zones, of course, is someone already on opioids for their chronic non-cancer pain and helping them to create a weaning plan to come off those. Sorry, Chris, just to add.
Yeah, I think that's... oh, sorry, Jenny, you go.
No, I think that group of long-term acute patients, so the ongoing nociception, and one of the classics I would say is somebody with an external fixateur, and I often find my team trying to cut them back each time they come in, and yet until they have that nociceptive input reduced, at which time they tend to come off very easily. I think there can be a really good role for maintaining the opioid to match that ongoing nociception.
Okay, thank you very much. There's a good question here about real-time opioid monitoring and doctor shopping. So could you all give us your view about the utility of real-time opioid monitoring, whether it's going to help or not help, and how do you deal, so for instance, in New South Wales, there isn't real-time monitoring yet. How do you deal with this issue of doctor shopping?
If I can kick off, let me say I think it's an important step, but this is a systems challenge. So monitoring is good. However, monitoring alone is insufficient if we're just documenting that there is some unusual prescribing but not seeking to challenge that or do anything about it. That's an ineffective system. So I think, as I say, monitoring is good. One needs to build in the educational resources, the regulatory, legislative approaches alongside that, and the support, mentoring for people who may be prescribing in suboptimal ways. So it really needs a broad approach. And I guess also there's a question of what are we monitoring which drugs? Is it just opioids, or are there a whole range of other psychoactive or addictive substances that are part of the mix? So how do we work across teams to tackle all of those things?
I agree, Chris, and I think this is just one component of the response. One of the other things I'd like to talk about is in the States, there have been versions of real-time prescription monitoring rolled out in almost every state. And the difference in outcomes between all of those states can largely be put down to how multimodal that real-time prescription monitoring is. Is it associated with many drugs, good education of GPs, a public awareness campaign at the same time? Does it have regulatory backup? And I think we've done that so far quite well in Australia, is make real-time prescription monitoring multimodal as opposed to just this single thing that you roll out.
And just to add on that, I think one of the key advantages of real-time prescribing is that potential issues can be identified a lot sooner compared to our current models and how we identify them. So I think that in and of itself will be almost priceless in addition to helping ensure optimal patient outcomes.
Okay, thank you. Now here's a really practical question. I've got a patient on fentanyl patches, 75 micrograms. And I need to wean them off that and deprescribe the opioid. How do I do that?
I can do it. I actually have someone on the ward as we speak with this exact issue. But I think the answer is, I'll start it off, but I think the answer is first of having a good conversation with the patient about what the objective is here, why we're doing this, making sure that they have an understanding about what's going to happen to them afterwards. Patients often have perceptions about what the opioids are doing, and that's worth exploring. And once all of that's done, the patient's on the same page, happy to start with the deprescribing. The classic thing is to drop down by the dosage of the patch to 75, down to 50, down to 25. Often, and I'd love to hear your experience, Jenny and Chris, but I find that dose drops can be quite a big drop in all morphine equivalents for patients. So it might be worth considering giving a little bit of supplemental oxycodone, not quite to the same level as what they were at the previous patch, but that can sometimes help soften and make the likelihood of transition a lot more effective. I also think talking about withdrawal-associated hyperalgesia is quite important in this setting, and just education on that piece to patients, saying that the pain will get worse as the patch drops down, and that how long that's expected to last for.
I would add that the more anxious or fearful the patient, the slower and the smaller the steps. So, for example, you could, given there's a 12 mic patch, drop from the 75 to a 62 mic dose, the 50 plus the 12 patch, and come down in 12 mic increments. So yeah, that principle of going slower, which can be done by smaller steps downward and maybe a longer time interval on a given dosage step, is worth considering.
And also the principle of going slowly and stopping if you're running into trouble. It's much better to just stop at a level than have to bounce back up again because you've gone too slowly. I think that takes away some of the confidence in the process, and you lose some engagement with the patient.
Yeah.
Okay, thank you. Now there's an interesting question here that's going to let me do a plug for the Atlas. So it's saying, is there available data on opioid use and antidepressant medication use? And if there is that data, how can you use it?
I think if I can just chime in, Robert, before you do your plug for the Atlas, I think this issue of healthcare variation is fascinating. I know in the eyes of the Commission and all of us who practice in healthcare, I think. So yes, there is data around looking at variation in opioid prescribing and whether or not that is warranted. There does seem to be some unwarranted variation in practice around Australia. So I think that can be very useful data for us all to consider what might be underlying that variation in clinical practice. Is this something to do with the patient group in question, or is this more to do with the training and beliefs of the prescriber?
The other thing the Atlas gives you is the longitudinal data. So being able to see how much it's changing in your particular area. Some areas have stayed quite stable, while in other areas opioid use has gone up really substantially. So I find that quite valuable as well.
One thing can I make a quick comment additionally, Robert, about that? One of the interesting aspects that we've seen from our EPOC data across pain clinics in Australia and New Zealand is that when we analyse that outcome data across a broad range of measures, looking at what happens to the opioid, we find that those who are able to stop opioids get the best outcomes in all the other measures, which would include markers of depression, anxiety, stress, physical activity, and so forth. So it's not that those who come down and stop opioids get worse pain or worse mental health or lowered physical activity. It's the reverse of that. Those who are able to come off opioids do better in all the other measures.
Great, thank you. So clearly this is the Better Care Everywhere webinar series. And in this series, one of the major aims is for us to look at variation in healthcare and what the drivers of that variation in healthcare is. Tonight is the third of these sessions, and next week there'll be a session again looking at variation of healthcare. So I'd encourage everyone that's online to join us next week for that session. I'd like to thank Jenny, TJ, and Chris for a fantastic question and answer session and for their fantastic talks. And they were really useful, and they will now be available later this week on our website, the safetyandquality.gov.au website, for you to review, and more importantly for you to play to your colleagues, potentially in an in-service at your hospital or in your general practice or in your allied health practice, to try and bring your colleagues along with the use of opioids and analysis of variation. I'd like to thank the steering committee, and all those on the steering committee are mentioned on our website. Should you need CPD points, if you email the Commission at atlas@safetyandquality.gov.au, we'll send you a CPD certificate. There were lots of really interesting questions, some of which I didn't get to answer the panel. And so if you'd like to email us around any additional questions you have, already Chris on a previous time volunteered to help us answer your questions should you need other things further explored. So again, I'd like to encourage you to register for the remaining webinars. I'd like to thank again Jenny, Chris and TJ for being fantastic speakers, and I wish you all a great evening. Good night.